Now next speaker.
আমাদের একটু টাইম কনস্ট্রেইন্ট আছে,
Yes,
আমরা
sir. I know
একটু
that
স্কিপ করব।
it will be has to be done by 10 a.m. So I will definitely going to skip my talks a lot shorter than my expected time. So I'm going to talk about on cerebral palsy. As the term denotes, is the definitely a problem of the brain. Right? It's definitely a problem of the brain. But you have to remember 2 points. Though it's a problem of the brain, but the central nervous system includes the spinal cord also. But if you want to say it as cerebral palsy, all the spinal cord deformity or the muscular deformity should not be included over there. It is only solely confined to the brain. And second point, most important, the lesion or the problem related with the brain has to be fixed and non-progressive. It can deteriorate, but it has to be fixed. It should not be like that at the age of 2 years, the upper limb was involved. At the age of 6 years, lower left limb is involved. Not like that. All the things that were included should be persist from birth. Only that portion get deteriorated with time. But new area involvement, if that's supposed to be happen, then it's not a case of cerebral palsy. So remember these 2 points. It's the disease of the brain itself only. It should be fixed and non-progressive. And how this patient actually came to us? The parents came to us with one complaint. My child has already passed the walking age, but he or she is still not walking. Or even if he is walking, it's not a normal walk. At that level, they started to come. They do not come at birth because the CP patient at birth remains almost like a normal child. It is very difficult to identify it. But if you see that if the child has a walking difficulty and since birth, since walking is he is not walking normally, then this disease should keep in your mind as a differential diagnosis. And what you should look for. This is the general picture of a cerebral palsy. Almost like an idiotic look and vacant look. You are talking to them, but they are not paying attention and they cannot obey your command properly. Then you can suspect that this can be a case of cerebral palsy. Etiology, whatever the etiology is, the main concern is only one. Any episode leading to hypoxia to the neonatal brain will lead to cerebral palsy. It can be a cardiovascular accident, like a heart stop. You started the CPR but resuscitated after a little bit later on. It can be a torch infection. It can be a low birth, sepsis, anything that lead to hypoxia of the brain will be a etiology of cerebral palsy. Now, if you want to mention the diagnosis, then only stating the cerebral palsy is actually not good enough. You have to mention its type. It can be either spastic or it can be a hypotonic. But hypotonic variety will be converted to a spastic later on. So most of the time, cerebral palsy means spasticity is there. And the next point you need to involve is in your diagnosis that which part of the body is involved. If one half is involved, hemiplegic. If the 4 limbs but the trunk are spared, then it is diplegic. If the whole 4 limbs and the trunk is all involved together, then we call it quadriplegic. So your diagnosis should be like this: spastic hemiplegic CP, hypotonic quadriplegic CP, something like that. Just don't utter just simply cerebral palsy. In history, you look for few important things. Number 1, is the baby preterm, premature or not? It's a very important point because most of the preterm babies falls into this cerebral palsy category. Then you look for immediate cry after birth or not, because you all know when the baby cried, his or her lungs started to work at that time. If crying is delayed, respiration is delayed, you already cut the umbilical cord, so the brain is deprived of oxygen. So immediate cry is a very important thing, and if the parents give that the child has a delayed cry, then the chances of cerebral palsy started to increase. Okay, so 2 important points: preterm and delayed cry. These 2 important points you have to look for it. And once they are there, then you look for the developmental milestone. I am sure that all of you, especially the pediatrics ones, people all knew about it. Because normally a child, neck stability developed by 3 months, a child usually sits by 6 months, started to stand near about 9 months, and started to walk near about 12 months. If this child were able to do all of this, but outside this barrier, his neck stability near about 9 months, he was able to sit by about 18 months, started to walk 2 years, started to stand near about 1.5 years, and then you have a strong susceptibility of cerebral palsy. So preterm, delayed cry, delayed milestone of development, and the left part of the body involved are fixed, new areas are not getting involved. This gives you suspicion of a cerebral palsy. What are the deformities it occurs? It involves both the upper and lower limb, but we as an orthopedician are mainly concerned with the lower limbs, because unless or until you fix the lower limb, the child will not be a mobile one. If he or she does not move, then his or her development will be delayed also. So foot, ankle, knee and hip, all these joints become contracted, deformed, and that makes it difficult to walk. And that gives you the idea of what are the types of gait that we develop in case of CP. And these are the gaits you have to look for whenever a CP patient is in front of you. I am showing you just some example. This is what we call crouch gait. Look at how the child walks. Hip is in flexion, his knee is flexed, but look at the foot. It is completely in touch with the floor. It does not raise up his hip. So this is what we call crouch gait, and this is definitely not a normal gait. If you walk like this, I am quite sure that you will not be able to walk within this, across this room only. You will be fatigued. So this is what we call crouch gait. Second one is quite opposite but very much similar. This is what we call jumping gait. The hip is again flexed, knee is flexed, but look at the ankle. He is actually walking on his toes. So the heel is actually raised up. This is what we call jumping gait. And these two gaits are very much common in cerebral palsy, and I can assure you the people, the parents will come with their child with either one of these complaints, that he or she were not able to walk normally, not walk at all, or even if he walks, they walk either one of them. So you have to remember these two gaits, jumping gait and crouch gait. And there is another one that we call scissor gait, that can be addition to previous two gaits. Only the foot crosses the midlines. Look how the child walks. His one foot crosses the midline while progressing forward. This is what we call scissor gait. Treatment. Most of the time we go for medical treatment and some in form of physiotherapy. Very rarely we can go for surgical treatment if the medical and physiotherapy failed. And at around 8 years of age, we usually go for surgery. But remember, the lesion is in the brain. But we as an orthopedician, we are dealing with the muscle balance around and across the joint. So we are not doing anything for the pain. So you have to remember, never forget to mention these things to the parents. After the treatment, medical, physiotherapy, or by surgical treatment, the child will walk definitely in a better way, but will never walk normally. This information has to be given to the parents. Otherwise, they will roam around all around the world for a better treatment. You have to ensure them that he or she will definitely walk better, much better than what he is doing right now. But don't expect a normal walk from them. So my take-home message: prenatal, perinatal, and postnatal hypoxia or infection. If this history are there, then it will give you the suspicion of cerebral palsy. It's the result of a brain lesion only. It's a fixed, non-progressive, and spinal cord and musculature with deformities or pathologies has to be excluded from it. Delayed milestone of development is another strong suspicion which will give you the suspicion of cerebral palsy. Both surgical and non-surgical management is there, but it's mostly symptomatic. It's only aimed to improve the condition of the patient, but he or she will not be able to be a normal person again. And always cerebral palsy is a multidisciplinary approach. Pediatrician, orthopedician, neuromedicine specialist, physiotherapist, everyone has their role from their own perspective point of view, but all aim for only one goal: make the child ambulatory and self-dependent so that they do not become burden to the society. Thank you.